Okay, then we move to the next session about sagittal balance and prostheses. So I call Jean-Yves Lazennec for the first talk.
My presentation is a very UMIL paper, and the aim is to introduce the other paper regarding the question we ask to ourselves regarding what is a good indication for those patients with abnormal sagittal balance. We are accustomed to look at plain X-ray as a flexion or extension. We are not accustomed to see those animation, and mainly we are not accustomed to look at the center of rotation, despite new technologies now are available for this. On peut revenir en arrière? Okay. So when we want to look at anterior disc replacement in atypical sagittal balance, we have a lot of questions. First, what occurs about on disc replacement on a level adjacent to a fusion or a stiff spine. We discussed about this. When we have an atypical cervical spine alignment and in two-level cases. And the questions are about range of motion, translation. I shall not discuss translation, but I shall speak a little bit about range of motion, mean center of rotation, and something we have discussed a little bit about lumbar spine, the flexion-extension ratio. What is the neutral position of our patient? So we are accustomed to look at the global range of motion, but what is interesting is to see the quality of this global range of motion. And we were interested in our study to look at the ratio between flexion and extension. There is not a lot of papers regarding this, and it is very different from according to the level. Here, C7, T1 level, and here you see, for example, C3, C4 level. It is very different. And when we look at our patient, it is interesting to ask them to do the classical plane X-ray we do in normal position, and then to do a flexion and to an extension, and to look at the difference regarding this. And look at those cases, for example. This is a neutral position of some patient. In those patients, there is a kyphosis in the neutral position of the prosthesis. So can we control this, and what are the side effects of such situation? We are also accustomed to look at the center of rotation, mean center of rotation. We look at the anatomical book, and we know that there is this distribution, this typical distribution of the center of rotation. But when we look at our everyday life patient, I don't know if you see this very well, but now we have very interesting tools showing we are able to reconstruct very easily the center of rotation of those patients when doing relocation of the images. And it is very interesting to see that in some cases, I choose a case with a very atypical center of rotation. You see this patient has a very posterior center of rotation. When we look at our plain X-ray flexion and extension, we cannot imagine really where is the center of rotation. It is very surprising. And in some papers, very honest paper, it is shown that with some prostheses and in some cases, we have the center of rotation. This is a published paper in the middle of the prosthesis, which is not correct. And in fact, when we look at those images, those animation, it is interesting to see that if you have more anterior translation, you have a more lower center of rotation. And if you have more flexion extension, you have a tendency to have a higher center of rotation. It is theory, but it is very strange to see that with our basic X-ray, we are able to demonstrate this and to look at this. In addition, the center of rotation is influenced, we have seen, by the location, but also by aging. There is a very interesting paper about the kinematic study with relationship to the level and the aging. And look at this. I go from C3, C4, C4, C5, C5, C6, C6, C7, and you see with more degeneration and more aging of the patient. So we have to solve very complex problem. We have perhaps to solve this problem with one prosthesis, with different adjustment of the level according to the this different adjustment of the center of rotation according to the level. And in addition, our patients are not young and sexy. They have also degeneration of the facet and degeneration, previous degeneration. So it is also interesting to look at the evolution of the center of rotation. This is a UMIL study we have presented 2 times, and which is on the way for publication, 2 years follow-up. This is the evolution of the center of rotation of a group of patients. You see, by the time, you see the location of the center of rotation is moving. You can say to me, okay, it is your prostheses are the responsible of this, but look at this. There are also modification of the cloud of the center of rotation at the adjacent level. How can we control this? Perhaps we don't control this because we don't know this really. And another example, at the C6, C7 level, you see the modification of the center of rotation at the adjacent level. So we have a lot of things to discover. So if we have to improve our cervical disc replacement, probably we have to take care about the global range of motion, but perhaps to have huge range of motion is not always a solution. We need to have to look at the segmental translation. I don't speak of this today, but we have to look at the segmental rotation and the balance between flexion and extension. So if we have disc replacement adjacent to fusion or a stiff spine, problems may occur regarding the location of the center of rotation, what are the location of this center of rotation, and the perturbation of the ratio between flexion and extension. I want just to share with you some cases. I hope it will, yes, it works. And you see this patient at the posterior plate. You see the problem is not the implant. We just here, we are discussing, looking at what is occurring. And if you look at this, you see here the location here of the center of rotation. You see this posterior translation, and very often there is a posterior translation and a superior migration of the center of rotation. And it is not very complex to do this type of study with the modern tools we have. Look at this other case. This patient has a cage, a resorbable cage, a very old resorbable cage here, and you see the same phenomenon. Okay. You see the same phenomenon. In this case, you see the center of rotation is just near the center of the prosthesis. So a lot of side effect we have difficulties to imagine. Another case here, you see always the same tendency to the upper and posterior migration of the center of rotation. So when we have a prosthesis adjacent to a 2-level prosthesis, you see, okay, you have side effect. You see the center of rotation is inside of the prosthesis. You can say to me, okay, it is because of the type of prosthesis. When you look at different type of mechanical prosthesis, you have this type of effect. So 2 messages: superior migration of center of rotation, and this problem is very evident. Whatever you study, mainly the flexion or mainly the extension. Look at this case, for example. For extension, you have the rotation center inside of the prosthesis and even during flexion. So a very strange side effect. Second question, some colleagues will speak about this. What occurs if we do prosthesis in kyphotic spine? In fact, you have here a patient with, it seems, kyphotic, and you see, despite this, there is an ability for adaptation. So we have to ask to ourselves, what are the patients where we can expect an adaptation for extension? And in this case, for example, you have much less adaptation for extension. So do we have any solution to predict those patients with more adaptation possibility for extension. There is a very interesting paper published regarding the impact of the T1 sacral slope. I think it is very interesting because if you look at your patient, even if you don't do animation as I did, you have patient with a very high sacral slope, not sacral slope, T1 slope. It is quite an equivalent of the sacral slope. And it is very strange to see that some patients have a very low T1 slope. And at the beginning, I was looking at this paper as a strange paper. And I felt it was very interesting because it was quite like lumbopelvic parameter. But this paper is very interesting. I want to share with you one or two cases. You have here a patient with limited extension ability. And you see it's very strange because this T1 slope is very low. And if you study with the animation the location of the center of rotation, you may have very atypical center of rotation. Again, a patient with very limited adaptation of extension. And you see this patient is, perhaps we shall discuss about this, his neutral position is with a kyphotic prosthesis. Why? Why this neutral position? Here, a patient with a high adaptation ability, you see the neutral position is with significant lordosis inside of the prosthesis, and you see the balance of mobility is completely different from the other case I shown to you. So probably we have to discover new thing about this. I show you here this case with the location of the center of rotation for extension and for flexion. Again, okay, another case, you see those patients very often have a tendency to have a kyphotic neutral position with mechanical prosthesis. It's the same with two-level prosthesis. We can have the same thinking. Look at this again with this type of adaptation between the neutral position, hyperextension, and hyperflexion. Another case, and you see this case, and you see with those two prostheses, the center of rotation are not where we expect those center of rotation to be. Look at this. One of the prostheses is a slave of the other. One has a normal center of rotation, expected center of rotation, and here, this center of rotation is inside of the prosthesis. Probably a case of failure of abnormal evolution. So to conclude, this paper is very humble. It's only raised new question. I think personally that it is interesting to have lateral X-ray, flexion extension. Perhaps the message is to do neutral lateral X-ray and flexion and extension, and to look at this T1 slope. Perhaps all kyphotic people are not the same. Some have more extension ability, others have less extension ability just because of this cervical thoracic junction. Thank you.
Thank you, Jean-Yves. Some questions about the paper of Dr. Lazennec about the sagittal balance and disc prosthesis. Dr. Rischke?
Did you see a change of this phenomenon in viscoelastic total disc replacement yet?
I did not want to discuss this because I did not want to push one device better than the other. But what the question is, if we have different level to treat, different sagittal balance to treat, and different level of degeneration of the facet, can we imagine we can treat this with a non-adaptative implant? But I am a little bit disturbed to answer this way because other colleagues have a lot of experience with cervical disc. Of course, you see the complication of other implants. Today, we did not see such problem. What I can say is it is very strange to see the adaptation of the patient by the time. This cloud of center of rotation, this adaptation. And we don't know anything about this.
Maybe Maybe I give you some comment. There was a lecture from Punjabi so 2 years ago at the ISS Congress, and he showed similar cases with the changings of the center of rotation in cervical spine, and he has noted a very interesting statement that only a freedom prosthesis with 6 degrees freedom is able to compensate the different center of rotations of a cervical spine. So that's what I meant. It was an interesting statement without any statement to a different prosthesis, but it has to be a viscoelastic prosthesis is only able to do it.
I think the problem is perhaps we don't analyze in the scientific way really the sagittal balance of the cervical spine. We have a lot of things to understand perhaps.